All right, so welcome everyone to the Penn State College of Medicine Understanding Primary Immunodeficiency. It's a Project Echo Clinician Education Series, and we're delighted to have you join us today. My name is Jackie. I'm a member of the Echo team. My colleague Caitlin is also online. So if you have any technical questions or issues, feel free to reach out to either of us. If you've not already done so, please make sure that you're logged in with a name that we can identify. If we can't identify it, go ahead and put your name and your email address into the chat for us. If you're joining with other people in the room, please include their names as well. Of course, we ask that you stay muted, but feel free to unmute or use the chat at any point for communicating with us, providing questions or answers. Please remember that when we talk about cases, no personally identifiable information or PHI is allowed. We are recording these sessions for educational and quality improvement purposes, and I always share all materials after every session. In the spirit of Project Echo's I'll Teach, I'll Learn philosophy, we're always on a first name basis during our sessions. So today we're going to have a brief talk on the rare of the rare, and that will be by Caroline Crow. And then we're going to have a case discussion. And thank you again, Karen, for submitting that case. It looks like it's going to be an interesting conversation. Again, during the presentation and case, feel free to put your questions into the chat. We have a team of specialists online. I'm going to ask them to introduce themselves shortly, and they'll help to field questions. But again, it's I'll teach, I'll learn, so everyone can share questions and answers. So let me start. Megan, I'm going to start with you, and then you can let me know if Catherine has joined.
Yes. Hi, everyone. My name is Megan Messick, and I'm the Director of Education at the Immune Deficiency Foundation. And I'm also joined today by one of my colleagues who I'll allow to introduce herself next.
Hi, I'm Catherine Lontock. I am the Director of Science and Policy Communications at IDF.
Hi, Catherine. Welcome. Thank you. So for those who've been with us before, Catherine is here because Colleen is not available today. So we'll certainly miss her. Ken.
Good. Let's see. It's morning for me, afternoon for a lot of you. I'm Ken Bass, and I am a patient with primary immune deficiency. I have CVID, and I also serve as a support group leader for other PI patients here in Texas.
Hi, thanks, Ken. Diana.
My name is Diana, and I am the mother of a child with PI.
Do you still have your little visitor with you?
No.
Okay. At some point, if you'd like to, feel free to introduce him or her to the rest of the group later.
Sure.
Diana is fostering an adorable little kitten right now, so we got to see the little guy earlier on this call. Paula.
Hi, everyone. I'm Paula. Now I'm a physician that takes care of patients with primary immunodeficiency. I work as an allergy and immunology physician at Hershey Medical Center.
Thanks, Paula. And Caroline, I'm going to just turn it over to you. You can introduce yourself and go right into your slides.
Great. Let me just share my screen. Make sure I find the right one. Does that show up properly? Do I need to put it in?
Yeah, it's not in slideshow view yet.
How is that? Okay. So hi, everyone. My name is Caroline Kuo. I'm an immunologist at UCLA. So thank you very much for inviting me to speak today. I'm going to try to give a quick overview of newborn screening for severe combined immune deficiency. Okay. Let me go through these slides. Okay. So all right, so this is the title slide. These are some of the main objectives that I'll try to cover today. So to understand how TREC newborn screening detects SCID, to be aware of other conditions that can result in abnormal TREC newborn screening results besides SCID, to know what to do in the event of an abnormal screen, know the basic immune workup of a healthy newborn, and identify definitive treatment options for SCID. So the recommendation for newborn screening for SCID was actually made officially in 2010. And as many of you know, the implementation of newborn screening tests is done on a state-to-state basis. So this actually took, quite a few years to get it, fully implemented into all the US. So when I used to give these talks, I'd have to update my my map every year. But fortunately, since 2018, it's been universally implemented in the US. So I get to keep using the same map now. So why do we screen for SCID in the newborn screening panel? So importantly, it's not apparent from the newborn physical exam in most cases. Most babies born with severe combined immunodeficiency look like just any other healthy newborn. In addition, the family history is not always helpful. So we used to think that, if there was a family member with SCID or with an immune deficiency, that their siblings would be more easily picked up, but that there have been studies done looking at that, and it turns out that's not really the case. And actually, the majority of cases of SCID are sporadic, so they occur randomly, and so there is no family history. We also know that a delay in diagnosis and treatment can lead to significant morbidity and early death. We also know that effective treatment is available. And when you do the math, it's cost effective for patients to undergo definitive treatment earlier than it is later. And then in terms of the testing itself, it's simple and it's inexpensive. So I'll go over a little bit more about how the testing works, but these are the reasons why this test was added to the newborn screening panel. So a big reason why this was added is because we now know, and we've sort of known all the way along, but now there are more definitive studies that have shown that the best outcomes in terms of those who are treated with stem cell transplant for SCID are those who are treated at less than 3.5 months of age. So you can tell that's pretty young. So really, if we didn't have newborn screening, many of the patients were getting picked up after that. So that's one. If you can try to get them treated before 3.5 months of age, that would be the best. And then if they're older than 3.5 months of age, then the next most important thing is to have them be infection-free. Or if they are not infection-free, to try to make sure that their infections are resolved before they move into transplant. And then infants who were 3.5 months old with active infections at the time of transplant had the worst outcome with 50% overall survival. So this is how newborn screening works. So newborn screening for SCID involves quantification of T cell receptor excision circles in neonatal dried blood spots. So we call this TREX. So TREX are extra chromosomal DNA byproducts of T cell receptor rearrangement, and it's only expressed in T cells of thymic origin. So I'll have a little bit more information in the next slide, but what this practically looks like is on the left, in the left bottom, you can see, we always collect dried blood spots on Guthrie cards. And they're actually, at least in the state of California, they've been stored since 1982. So nothing, to my knowledge, has been thrown away since 1982. And all it takes for this TREC analysis is a 3 millimeter hole punch from this dried blood spot. So it's a very tiny punch, and which represents about 3 microliters of blood. You can take that little punch and you sort of soak it in a liquid, and then you can analyze for DNA. So T cell receptor excision circles detects low T cells or impaired T cell development. And the way that it does that is that, in order for T cells to be functional, after they're formed in the bone marrow, they have to travel to the thymus to mature. And part of that maturation process is rearranging and maturing their T cell receptor. And so you may remember something called VDJ recombination, where the way we get diversity in our T cell receptor is by putting together different combinations of V segments, with a different combination of D and a different combination of J. And so that gives us then a lot of diversity in our T cells. And it turns out that when we recombine, different segments together, it forms these little circles. These little circles are snipped out in between the regions that we're not using. And when these circles are snipped out, they're actually quite stable in the blood because they don't have free DNA ends. And the area in which they stick together are these joining signal ends. And those sequences are highly conserved. And so you can just do PCR in anyone, and you can quantify the number of these extra chromosomal DNA circles, which represent TRECs, to see how the T cell production is in an individual. So we know that each TREC is derived from a T cell of thymic origin. So it comes from a naive T cell. It's not from T cells that are peripherally expanded. And each T cell of thymic origin contains only one TREC. So we can't, somehow overinflate the number of TRECs that we're quantifying. As I mentioned before, the SCID screening protocol is different, a little bit different in every state. But I wanted to share with you sort of the general overview of how it's done in California, so that you have a background as to what happens with these infant dried blood spots. So if the initial screening results are negative, there's no further testing needed. In California, if it's positive, then we arrange for the infant to have a CBC with diff, as well as a lymphocyte subset analysis by flow cytometry on whole blood. And that can be done commercially. We have an arrangement with a commercial lab, or it can be done at an institution, depending on if the baby is hospitalized or not. And then if the screening results are indeterminate, then we repeat the filter paper test. And then if there's another indeterminate test after that, then they also undergo CBC with diff and lymphocyte subset analysis. When there is a positive screen, our newborn screening coordinator will inform the primary MD. So that's usually a pediatrician or a neonatologist if the baby is still hospitalized, and let them know that further testing is required. They will help to arrange for the blood draw either at the birth hospital or at Quest Diagnostics. That's the lab that we use in California. And then we have immunology physicians at UCSF, CHLA, and UCLA that review these results, and then we determine whether or not we need to see these babies, or if they're actually normal. During this time, rotavirus vaccination and other live vaccines are held, and if blood products are needed, they need to be CMV negative or leukoreduced. In terms of the immunology team, we usually contact the family within 24 hours of receiving the referral, just to get a little bit of history and to give patients a little bit of guidance. And at home, the baby should be isolated from all visitors. Flowers and plants need to be removed from the room. No one with viral respiratory illnesses should be allowed within 6 feet. And we need to stop breastfeeding and start age-appropriate formula. I'm not going to go into all the specific immunologic phenotypes of SCID. There's many different genetic forms of SCID, but the important thing to note is all of them lack T cells, so they're all what we call T minus. A group of them will have B cells, and a group of them will not have B cells, and some of them will have NK cells, and some of them will not have NK cells. So you can kind of see how we divide the different diagnoses, but they all don't have T cells. What is the initial immunologic evaluation for suspected SCID? So CBC is always done, and it'll show a low absolute lymphocyte count. What I always try to emphasize is that the CD3 T cell count is typically less than 300, although not always the case. And what's really important to remember for a newborn is that their lymphocyte count is in the range of 2,500. It's quite high. And so we have to remember not to use the normal limits for an adult or for an older child or a teenager when we look at lymphocyte counts for a newborn. So if we have a newborn that has a lymphocyte count of 1,000, that's still low, even though it sounds high. We also do flow cytometry, looking at different T cell markers, B cell markers, and NK cell markers. And importantly, we look at T cell function. So similarly to when we evaluate for antibody deficiency, where we quantify antibodies and look at the function of antibodies, we do that also for T cells. So we quantify them, and then we also make sure that they are functioning abnormally or normally. And the way that we do that is usually through lymphocyte proliferation studies, in which T cells from the baby are isolated and cultured in a dish and exposed to different stimuli. Typically for newborns, we just use mitogens. So that includes PHA, CON A, and poquine mitogen. They just stimulate T cells, and we just want to know that the T cells are working. You can also measure immunoglobulin levels, although, we have to remember that, in the first months of life, a full-term baby's immunoglobulin levels usually reflect that of the mother, and then HIV PCR. If the initial lymphocyte subsets show profound lymphopenia or very low or absent naive T cells, so we use CD45RA as a marker, but these are the T cells that are coming out of the thymus, those new T cells that are TRK producing, then a presumptive diagnosis of SCID will be made. Typical SCID is less than 300. And then leaky SCID is over 300. So, sometimes we get a baby with 600 T cells. So we call that leaky SCID, but we can use other measures such as T cell function and genotyping to confirm our diagnosis of SCID. Antimicrobial prophylaxis includes Bactrim at the doses shown here, and then fluconazole, and then valganciclovir if we think that it's needed. If once SCID is confirmed, we also generally start patients on immunoglobulin replacement. They receive palivizumab prophylaxis if it's during the RSV season. As I mentioned earlier, they should receive CMV negative, leukodepleted, irradiated blood products. And then if they're hospitalized, we preferentially place them in rooms that have integrated HEPA filters. And then just a little one slide on breastfeeding and possible SCID. So whenever we get a possible SCID screening, we do tell mothers to stop breastfeeding until we know their CMV antibody status. I will say this policy varies from institution to institution, but at UCLA, and I think at many institutions in California, we will often recommend that they switch over to formula or pasteurized breast milk until CMV status is confirmed. If the mother has an antibody deficiency herself, then we assume that she could still be CMV positive with just negative antibodies. We let moms breastfeed again if they are CMV PCR negative, meaning they don't have any active CMV, and their antibody tests are negative. So they have to be both IgG and IgM negative. And the reason we do that is because we know that healthy individuals who have previously had CMV infection can still spontaneously shed some CMV in their breast milk, and the risk of passing that to a baby with true SCID would be very high especially if that baby ultimately needs to go through transplant. There's further evaluation that can be done. I'm not going to read through these, but just, because these are usually done a little bit later to confirm the diagnosis of SCID. But there's a lot of other, genetic testing, enzyme testing to look for certain forms of SCID, imaging, things like that to look for other abnormalities. These are some of the other conditions that are detected by TRK. I like to show this because it emphasizes to us that not everyone with a low TRK has SCID. So you can see there's a lot of syndromes that are identified, DeGeorge being one of the most common identified by TRK newborn screening. But there's also secondary reasons for T cell loss, like having a hydropic infant, cardiac abnormalities, GI loss. And then very importantly, preterm infants very commonly have low TRK newborn screening. And so in those individuals, if we track their TRK over time, you can see that as they gain weight and as they grow, the TRKs and the T cell levels very quickly normalize. And so in premature infants, we really need to make sure we don't act too quickly, especially if we think that there's no other concerning history. Finally, the treatment options for adenosine deaminase deficiency type SCID, there is enzyme replacement for that. It's generally not considered the best for lifelong treatment. It's because the definitive treatment for all forms of SCID is hematopoietic stem cell transplant. It generally requires minimal to no conditioning. And then we do have to remember that there are some forms of SCID that have radiation sensitivity. And so those individuals need to have different forms of conditioning. There's also gene therapy with autologous transplant that is now available for 4 types of SCID: adenosine deaminase deficiency, X-linked SCID, Artemis SCID, and then there's a new trial for gene therapy for RAG1 that is in Europe only. So in summary, newborn screening for SCID is a simple but effective way to detect low T cell production in infants. TREC analysis quantifies DNA byproducts of naive T cells of thymic origin. SCID newborn screening identifies other causes of T cell lymphopenia besides SCID. And then allogeneic hematopoietic stem cell transplant for SCID is best when performed when patients are young, so preferably less than 3.5 months of age and infection-free. And I'll close by just listing some references and resources that I think have been really helpful for some of our SCID patients through the IDF, through the Jeffrey Modell Foundation, and through SCID.net. So thank you very much. I guess I'll leave it here.
Thank you so much for sharing that. Are there any questions before we move into the case? All right, well, if you do have
If there's no questions, I just wanted to quickly, first of all, thank you so much for the talk. In terms of the MMR vaccination, what thoughts do you have with regards to the administration of that? I know you mentioned rotavirus.
Yeah, so I mean, MMR is not usually given until 1 year of age, and so you would hope that have SCID, they're diagnosed by then. So that's why I only mentioned the rotavirus vaccine. Yeah.
Thank you.
So if there are questions, put them in the chat. Feel free to unmute, but also we'll keep an eye on the chat. So Karen, I'm going to share your case slides and then you just tell me when to advance. Is that okay?
Sure thing. I'm going to pull just her chart really quick in case
okay.
there's clarifying questions.
All
okay.
Right. While you're doing that, Caroline, can you see if there's a question from Rita?
Yes.
Okay. Do you want to address that?
Sure. There was a question about our approach to premature infants and positive screening. So we get a lot of these referrals, and the nice thing is many times these very premature infants are in a NICU. They're hospitalized, and so we do the initial consult to be aware of those low TRECs and to see we measure their T cells at that time, but then we follow them. But then we just follow them over time if there is no other concerning history for SCID. So we may repeat, depending on how old they are, we may repeat the T cell panel every month just to trend the T cells and make sure that they go up. But we also have a lot of NICU babies who have other issues like chylothorax or protein loss. So we know that there's T cells being lost. And so those babies, we continue to follow them. We probably would check their T cells every month, but we know that the recovery for those infants are going to be much slower, especially if they have continued loss.
And in those babies, because they have the low TRECs, you're recommending avoidance of breastfeeding in the premature infants.
Yeah, we check mom CMV status, and if mom has had CMV, we do usually recommend stopping breastfeeding. We do have, at UCLA we actually acquired a machine that can pasteurize or irradiate the breast milk, and so we've used that in some of our infants with good success. But I recognize that that's not always available, and so I would say that if the TRECs are very low and the T cells remain very low, at some point genetic testing gets done, and if we rule out the the genetic causes of SCID and there's a high desire in the family to breastfeed, I think, we take that on a case-by-case basis. But in general, if we're at all worried that a baby might eventually need transplant, we try to be really careful about CMV status.
Thank you. So Karen, can you see the slides and just let me know when I can go to the next one if you want to walk us through this?
Yeah, I can give you guys background. So this patient, I asked the mom if it was okay to share. So I can give you some background on this patient. I don't know if it's on the next slide, but these are generally the questions that I was thinking of asking. So she has some genetic tests that I can give you the results that are a little abnormal. They're all VUSs, so there's nothing exactly that pinpoints to her immunodeficiency. And then she presented with recurrent sinusitis episodes that have improved with IVIG treatments. But she's still having some pressure and some discomfort and other issues where she gets a cold and it just knocks her out pretty bad. And then just moving forward as she gets into the teenager life, mom really is hesitant to continue like treatments that require monthly visits. She's located it's the Central Valley in California, so they don't have immunology there. They either go to UCLA, CHLA, or up north at Stanford and UCSF. So anytime that they have to check in with immunology, they do have to do a telehealth, if not an in-person. We were able to maneuver some site that allowed us to give her the IVIG, but it's been really tough to keep it going just because it's an adult hospital and they're not very kid friendly, so it's been harder to like get that approved. We do have a children's hospital, but again, they don't have immunology, and it's hard to access the orders when the doctor is not necessarily accredited from the children's hospital, because we're a site that's accredited with UCSF Fresno, so it's a satellite clinic, and we practice at Community Regional Medical Center, which is mostly like an adult hospital, but they do have a PEDS ICU unit. So our girl, if you want to go to the next slide, so this is an 8-year-old female. Her mom actually works at the hospital as an admin. She comes up from a non-smoking home. No one around in her immediate family smokes. She lives with her parents and a younger sibling that is also pretty healthy. She was immunized with the exception of the COVID vax series. We tried really hard to convince mom to consider COVID, but even immunology was hesitant just because we didn't know if that was going to cause her more issues, or we had a couple kids that had dysautonomia and they got the COVID vaccine, and then that kind of triggered their symptoms of discomfort and pain. So we kind of accepted mom's reasoning on this one. And we also asked immunology and they didn't really necessarily push, but that was something that mom was not going to budge on. Indoor pets, she has a dog, a cat, and a rabbit. They're all located in a section of her house. They're not in her room, but honestly speaking, I've talked to this girl on the side and her rabbit tends to be in her bed a lot. And then the past medical history. So she came to Pete's Pulmo with the diagnosis of asthma and recurrent sinopulmonary diseases. We did a PFT on her and it was normal. There wasn't a lot of reversibility. There wasn't any real reversibility on her PFT. So we kind of dismissed that asthma component. We did check IgG subclasses and immunoquants, and that did show IgG deficiency. And that's when we sent her to immunology. And then she had a past diagnosis. I couldn't find who exactly gave her this, but it was hypogammaglobulinemia. And then she had the recurrent sinusitis. So again, like she had about 7 to 9 sinus episodes, and we're very hesitant to give antibiotics unless like it's real, it's prolonged. She's having a lot of discomfort and whatnot. But for her, like a cold, like a URI would start with a congestion, kind of like a hacky cough, But then within like 24 to 48 hours, she was full on, like you could see how much redness around her eyes. And she would get these like chunky, like white discharge from her nose. Like as she coughed, you could see how thick the mucus was, and a lot of discomfort. She was missing about 1 to 2 weeks of school at a time. The school was very helpful in the case of getting a 504 plan for her, and we just kept writing notes for her. So her pediatrician basically asked us, like, what could we do in the case that present, like similar cases to this in the Central Valley of California. We get a lot of fungal infections, so a lot of aspergillosis. We've been seeing can't remember the other one, but it's all pretty much like when we do the bronch, we get the sample and we treat with antifungals, and within a couple of months, like usually we'll do 3 months, they'll have improvement in their asthma, in their cough, in their recurrent like issues. So we were like, okay, this chunky mucus, like it just looks weird. So she did go into an EGD bronch. It was pretty unremarkable. I think the only thing positive was H. influenzae type A. We kept giving her a mock. We didn't give her a mox. I think we kept giving her like ceftonir and augmentin. We did do a prolonged course a couple times of 20 days just to see if we could knock it out, because as soon as she stopped it, she would go back full blown. And we were trying to get her into immunology. So immunology, I think, took about 3 to 6 months to get her in at UCSF. And then once they saw her, they repeated a lot of the labs that we did, and they did start on IVIG with an IG trough of greater than 800. So every 6 months, she's getting these labs, and every month she gets, I believe, 25 grams of IVIG. So UCSF orders it, we reorder it through our hospital, and then she gets it. But in the last year, I do want to preface it with, she was out of school for COVID. So in the last year, she only received 1 antibiotic treatment, a 10-day course, I believe, of ceftonir while she was on IVIG. And then she's still having a lot of sinus pressure. So we did do like a respiratory allergy panel. She's been to allergy for the skin prick. Nothing has come up positive, but she's still having these sinus pressures. And I think on the next slide, there is imaging. This is her labs. So nothing pretty like, or nothing that I think immunology was very, very worried about, but these are the things that they noted. I'm not in immunology, so I just wanted to post this for the group. And then her medications, all she's on is either Zyrtec or Claritin. Sometimes she'll throw in Zysol if she's kind of gotten used to Zyrtec or Claritin. She does do sinus rinses. She does do like Flonase Acetylene when it's really bad. And the air quality in the valley, I would say 9 months out of 12 is probably bad. It's above 100 AQI. She lives on the outskirts, so there's just a lot of dirt around her surrounding areas. And I believe she was like in softball or something similar. So we worry about softball because they tend to do the mitten and the ground and then bring everything to their nose. So we had a lot of hesitation from her to do sinus rinses, but we're like, hey, like this might be helpful. So these are the 2 genetic results that we got. So our clinic did the PCD genetics just because a lot of these kids present with, interestingly enough, the DNA H8. So we've had a couple kids that had multiple DNA H8 arms or VUSs, but they still have a negative sweat chloride, they have a negative bronch lavage, and then a negative breast biopsy. And there was like no allergy panel that was positive. And then Immunology did the PID genetics, which are listed there. And I did write what one of them was associated that may be of interest, but other than that, nothing conclusive. So Immunology, oh, and you can continue to the next slide. This is the imaging. Nothing really significant, except for the sinuses. There was a little bit of mucosal thickening. We did send her to OMFS, and they didn't really necessarily think that there was anything egregious or anything that they could do. They just, again, said like, just do the sinus rinses and tried to get more on top of like flushing, but there was nothing that they said was like super abnormal. So for this group, I think that's the last slide, right? This is a timeline just for reference, but it would be like super helpful. And we have enlisted NIH to ask a couple questions on how to proceed with this girl, because we don't necessarily have we have the diagnosis of the hypogammaglobulinemia, but other than that, like we don't have too much more to go off of.
Just those labs that you had, the IgG, IgM, and IgA, was that before or after she started on the IVIG?
So she did get a set before, I believe those were before she started the IVIG. The subclasses have been repeated while she's on IVIG.
Okay, so we don't know, are we, just because they're I think they're normal, so just wanted to make sure. So, but
You're
her
right,
IgG was low at some point, or is this the lowest it's been?
You're right, doctor. So it was, those are from January of this year. So those are while she's on IVIG. Yeah.
Okay. Do we happen to know how low those immunoglobulins got, and what the?
Let me
It's
check.
okay if not.
Karen,
I
I
know
think,
I have them.
I think your
just have
slide actually had the initial, if you add up all the IgG subclasses, the total IgG was quite low, I think. I was trying to,
Okay.
if you show that initial, yeah, so like
Because those were still from
those still were when she was on it.
because that's pretty low. That's still, if you add up the 4 IgG subclasses, that's still 300, right? Less, or yeah.
Yeah, that's less than 300. So it's weird how it's not adding up, because those are from the same date, it seems like.
Those are from November. The other ones, I believe, are from January 2022.
Okay, and when did she start the IVIG?
Around the early part of last year.
Okay, interesting.
Yeah, that was something that is commented a lot, is that they were thinking that it would go up more, but it's not going as high as immunology would like, but they're pretty much just seeing her every 6 months. And so mom's at a loss, and we're also at a loss because we don't necessarily know what else to do with her. I'm happy that she's not missing as much school, but she is still missing a lot of school.
Does anybody have any questions or any comments regarding the case?
There's a question in the chat real quickly over T cell studies.
Oh, T cells, yeah.
T cells. B cell, no. So I have this is from 1/7/2022. So I have I don't know how to do this, but CD3 T cell is 82%, CD4 T cell is 53, CD8 T cell is 24.
Do you happen to have the absolute numbers by any chance?
Yes. So CD3 T cells absolute is 1,484. CD4 T cells absolute is 959. CD8 T cells absolute is 434.
Another comment. So here they're asking why IVIG and not sub-Q IG, or why not home infusions? What are the barriers there?
That honestly is all immunology. Like that was the suggestion from up north. NIH, we're still pending on their suggestion, and we just messaged them, I think, like a month ago. So we haven't heard back just yet, but it would be interesting. Do you recommend more of the sub-Q IG?
So I don't work with very much with pediatrics, so I would be very interested to hear other people's perspectives from sub-Q IG from my perspective. Caroline, any barriers? So from my perspective, there would be no known barrier for an 8-year-old to get sub-Q IG, but I wanted to get Caroline's opinion on that. Certainly home infusions would seem to make the most sense in this case. And I personally, anybody that I can get on sub-Q, I really push that hard, has a better steady state. People tend to tolerate it better, and it has the ability to just get it done at home. So that even, I mean, IV can be done at home too, but this is even easier, can be done by mom, etc. So I think most people do much better with sub-Q.
That's
Yeah,
interesting.
I would agree with that. I think that I really only have a very small, I could probably count down 3 patients who are on IV form for personal reasons, but you know, our skid babies even that are, you know, awaiting transplant, we actually, if they're discharged home, we start them on sub-Q immunoglobulin. So there really isn't that barrier based on age. They do quite well. And I think I saw in one of your slides that IV, like being on IVIG, has sort of disrupted the flow of their family life, and you know, I think that's a really good suggestion to consider sub-Q.
Yeah, no, I appreciate you all. I'm not sure who they messaged in NIH. I can check with my attending because I think it was a joint effort between my attending and the attending at in immunology. But that was one of the questions that mom had for us, is just like, as she gets older, when can she get off of it if she can? And then how does it not disrupt like her college life and her academics as she gets into harder classes in high school and things like that?
So I will say I have several college students that are on sub-Q, as you know, people that have transitioned from being a pediatric patient to an adult patient with primary immunodeficiency, and they do really well in terms of being able to administer the sub-Q on campus. So there's a graduated independence with that, right? Initially, a lot of mom has to do a lot, but I think in general, if the patient is motivated, they can do quite a bit independently. Additionally, if they, you know, want to travel like to home and things like that, they can do that. So most people do sub-Q once a week. There is a couple products where you can do monthly sub-Q therapy as well. So there's options in terms of flexibility. She's doing well. Does she have, and you mentioned a lot of sinus infections, but CT didn't look all that bad. It wasn't completely clear, but didn't really look all that bad. And so not a lot there. And bronchs have been reassuring. And has she had a lot of pneumonias? It
No.
doesn't sound like it.
No, it's all seems to be here. So we were like, it's a drainage issue, right? So she just has to stay on top of that. Or like it could be a PCD. Like we have a lot of kids who are not necessarily the textbook PCD, but they have these VUSs, and then they tend to have all this drainage all the time. I do think it's a play on like all of the issues in for air quality that happen to be the Central Valley. But other than that, like we couldn't think of anything else that could make her so susceptible. And even on her strep pneumococcal titers, she did get the pneumovax, but it wasn't like a great response.
And I see you've been on mute for a minute. Did you have something to add?
Yeah, I'm also a sinus sufferer and had a lot of the same symptoms you're talking about, where even on IgG therapy, you know, that I was still getting those. I'm going to put in a prescription that I was given, and this goes along with the rinse. And the idea is you rinse this twice a day for a month, with the goal of primary immune. You don't ever really get rid of anything. It seems like it just keeps coming back. And so this really set me free as far as did that for, and then I stopped having those constantly, the thick drainage and that always turned into infections and stuff like that. So that was my immunologist. He gave me that solution to put in a rinse bottle and then rinse twice a day for 1 month. And it made a huge difference for me. The other thing I was noting is that I saw the IgG at 863. I know a lot of the people that I work with, I don't know if that was a trough number or not, but a lot of the people I work with find out that symptoms improve when they get closer to 1,000. So I would wonder if the dosage of the Ig level, could be improved to help fight off some of the infections. That was my only input. Thank you.
Thank you so much for that. No, that when I list, that's the main reason I joined this ECHO program, is because we have a lot of kids that are similar to this presentation, where we basically enlist like all of our peds residents to try to solve them, just for the extra like literature background. But then I jump on top of just trying to figure out like what else can we do, because a lot of these kids, like they just are tired of coming to the office. They're tired of taking all this antibiotics. Like the antibiotics mess with her stomach so bad, and she's gotten really bad reflux from it. So we're trying really hard to not be so heavy on antibiotics. But if we don't give it to her eventually, then she ends up in the hospital, like going to urgent care and like all these other places where they probably won't give her the antibiotic that she truly needs. And then they poke her for a lot of other reasons. And I did see the question on ENT. So OMFS and ENT share the same residents. So they essentially did a workup for both, but I pulled one of the ENTs aside, and they basically said that they were just going to do like rinses again. There's nothing too much more to do. But in the future, once she stops growing, they were considering doing like a sinus surgery to help the drainage. I have kids that did the sinus surgery, and I will tell you, like, a lot of them didn't find too much relief post-surgery.
One question that I had for you, thank you, was, is she been having any issues with diarrhea at all?
Only while on antibiotics. So we put her on like the probiotic or tell her to do Yakult, and that seems to be okay. Why?
Just because of so she's actually, Ken made a good point that sometimes we do want these patients on a higher dose. And if Caroline, feel free to chip in. However, she's already, if I remember correctly, somewhere between 600 and 700 mg per kg of IVIG, which is actually a pretty high dose. We typically start people somewhere between 400 and 600. So the fact that she's over the 600 mg per kg is actually a pretty hefty dose. And if her troughs are on the lower end, 800 is actually pretty good, but wondering if she's having some issues with protein losing enteropathy, because that sometimes can be a reason why we can't get the troughs to the level that we want them to, and especially in the setting of, I'm not very familiar with her genetics, to be perfectly honest offhand. But I saw that it was associated with inflammatory bowel disease. So just kind of something that kind of popped into mind.
No, thank you. I can double check, Mom. I wasn't necessarily asking very deep GI questions, but I can definitely go back and recheck, even if it's like loose stools.
And one possibility is just checking a protein level and albumin, to make sure that is she holding on to protein in general, or is she having some sort of protein loss?
Okay. Thank you. That's very helpful.
Absolutely.
I was just gonna, oh, sorry.
Go ahead.
I was just gonna add in about the SCIG. My son has been on SCIG since he was 8, but what I saw in there was the how it's affecting family life, and going to the hospital so much. And the one thing that I reached out when my son was in the process of getting diagnosed and treatment. And the one thing that stuck out to me is we fought hard for the IgG replacement. We fought really hard. It was like a 9-month insurance battle. So we were so grateful when my son started treatment, and it was a positive thing. And the thing about her mom and parents and family getting support for what they're going through, it's often in the community of kids with medical needs that they're like, everybody says, oh, I'm so sorry you have to do this. I'm so sorry you're going through a hard time. But what we took from that was we were so excited and we were so positive, and we really were looking forward to treatment. We were looking forward to feeling better. And that mental aspect of being grateful and thankful versus so sad and upset about being sick, we try to look for the positives. So, you know, suggesting, you know, the IDF has networks for, I'm one of the co-leaders for the parents of children with PI, but getting together and changing that mindset instead of, you know, I'm so sorry, to we have treatments for these things and we can live a, you know, a full life and make all these experiences turn from sad to positive. And that's part of what I've done as a parent. Is it's not, you know, oh, I'm so sorry. I was like, oh, you know, we're going to the hospital. We are so thankful and lucky to get this treatment. But that SCIG really did open up a huge, you don't have to go to the hospital. You get to do it at home. For my kids, it's Thursday night and we are so excited because we get movie night, pizza night, whatever you want to order. And it's looked forward to in my family because it's a time where mom and dad are not cooking, cleaning, we are playing games, we are watching a movie, we are spending time together. So that positive attitude has to come from within the home instead of, you know, so sad that we're going through a hard thing. And so be it, it is hard, but that positive mental attitude does take such a more positive experience than what could be placed.
I love that so much.
It's we look
it's
forward
beautiful.
to we look forward to treatment days, which is every Thursday. He even infused in Florida last month on the beach. I said, you know what, let's take a beach photo. We're hooked up to the pump. But you can live a complete full life with proper precautions, but it's the mental aspect of it that I needed to change because I didn't like everybody telling him, I'm sorry. I said, well, we have to accept this and we're going to change how we present this to my child. And now even all my children look forward to infusion night and going to the hospital. You know, we don't have to go often anymore, like, but it's just it's a different way of thinking. And maybe as providers, explaining that to them, you know, obviously when the child's not around, but their opinions on it really do affect the child's viewpoint about how dismal this is or how lucky we are. And it's not to say that we don't have bad days, because there are certain, you know, I'm tired of of doing some things, but switching that mindset really does make a huge difference in a child that has medically complex issues. So that's just my 2 cents.
I love hearing that, and this could apply so well. Oh, sorry, go ahead.
I was going to say, using sub-Q, because it's done more frequent, that's also another way to help make that trough number stay elevated and consistent, more consistent with fighting, the bad stuff in your body. So that's another argument for sub-Q.
I love that. Yeah. Yeah. And this, I love the movie night or turning the sub-Q therapy into something positive, something that seems to fit this patient really well, like potentially doing it at home since travel is a big thing. Wanted to quickly just remind people. So one thing that Megan and Catherine sent was a primary immunodeficiency guide for young adults. That's in the chat. So anybody that is interested can look into that. And then also for your patient, Patty did say that she might be able to help with follow-up from the NIH, which is tremendous. Thank you, Patty. And additionally, Lisa Toth mentioned that she might be able to help with questions regarding sub-Q. So these are amazing resources that are being all united to help your patients. So I hope that that's very helpful. Does anybody have any last minute questions or before I close this session?
Thank you.
Okay.
Thank you so much.
Absolutely. Absolutely. Like that we were able to get some resources together and hopefully some people that you can connect with to help your patient out.
And Karen, thank you again for that case. And if anyone else has a case, we are looking for one for the next session, which is on June 5th. And it will be on comorbidities in PI. So please reach out to me if you have a case that you'd like or a question that you'd like to have as part of our discussion. And don't forget, if you're claiming CMEs, you do need to complete the evaluation that will come out right after today's session. So thank you, everyone. Have a wonderful day. We'll see you on June.
Thank you. So I wanted to thank Carolyn Kuhl for her fantastic lecture today on newborn screening. Just to quickly summarize, the newborn screening started in 2010 and now includes every single state in the US. And it is used via using tracks, which use excision circles that can be grabbed from just the punch card. This detects low T cells, although it can be non-specific for SCID and can be associated with other immunodeficiencies. And then we do have certain precautions that we use for SCID patients, including absence of breastfeeding, avoidance of live vaccines, and trying to get them into hematopoietic transplantation as soon as possible, ideally less than 3.5 months. And we had a wonderful case presented by Karen on a patient with immunoglobulin deficiency. So thank you, everyone, and thank you for being here, and see you on June 5th.